My name is Jamell Walker. I am an obstetrician and gynecologist, a generalist. I am the Associate Chief of Obstetrics and Gynecology at Jackson South Medical Center. And I'm also the Medical Director of JMG, the Women's Center at Jackson Medical Center. So that's who I am. How did I get there? I did undergrad at Stanford. I did a master's in public health at Harvard. And then I had the experience of my mom getting very sick and saw her surrounded by a bunch of medical students, and I said, I'm at least as smart as them. So I'm gonna go to medical school. So I went to medical school at Southern Illinois University and I did my residency at Tulane. I've had a very blessed life and I'm appreciative of all the experiences that I've been given. With that being said, how did I get to Jackson? I was working at another community health program in the area and had the opportunity to have breakfast with Don Steigman. And I expressed to him that I loved Jackson South and I wanted to be there. And he said, well, we're looking at expanding an obstetric program. I said, I'm your girl, make it happen. And he literally made it happen. So myself and Dr. Taliba Ahmed are the two employed Jackson South obstetricians and gynecologists. So that's how I came there. Now, what do I do on a daily basis? I am your vagina whisperer, right? I see all women of different ages and races, sizes, everything, you name it. I help you when you're an adolescent and you're figuring out your body and trying to figure out, why am I menstruating? What are these feelings? What are these emotions? I'm your lady when you get pregnant, right? And you're excited. I'm the lady that you see when you have your loss. I'm also the lady that when you start going through menopause and your body's going through these new changes and you're like, do I have a period? Why am I not menstruating? I'm that lady. And then I'm the lady that you see later in life when you're no longer menstruating, your vagina's becoming a little atrophic and it's making other changes and you still want to be sexually active. I help you make that happen. That's who I am. So here's what happens. When you decide that you want to get pregnant, my IVF patients are the patients that come see me before they even go find our reproductive endocrinologist. They come see me and they say, Dr. Walker, I'm thinking about getting pregnant. And I say, start taking a prenatal vitamin now. Make sure it has folate and DHA. Then we send them to the reproductive endocrinologist and they do their magic, which is a whole nother series, right? Reproductive endocrinology and infertility is the specialty of helping you to get pregnant. When they do their magic, they see you and keep you for about a 10-week process. So you get pregnant with them, they keep you till you're about 10 weeks. Once you become 10 weeks pregnant, they release you to a generalist obstetrician and gynecologist because they don't deliver babies. All right, so typically what we encourage you to do is about 6 to 7 weeks in your pregnancy, call us because 4 weeks from now, it's gonna take you about a month to get an appointment. And then you'll be good in about 10 to 11 weeks into your pregnancy, and then we start our regular process with you. Although you are considered a high-risk pregnancy, it's typically a normal pregnancy. You've done the hardest part already. Now we deal with the emotional and anxiety of being one of these precious pregnancies, right, of conception. And we also talk about making sure that you are doing all the different milestones of a normal pregnancy, because that's what we consider you unless you have health issues. I think the biggest tip I can tell you is everybody's caught up on taking your prenatal vitamin. If it makes you sick, don't take it, right? I'd rather you take a Flintstone multivitamin, but take 2, right? Because I want you to get all the nutrients that you need. I want you to eat a well-balanced diet. You're not eating for 2, you're eating for 1. That's like a Coke. You get an extra 300 calories a day, not a full meal. You only get to gain 25 pounds during your entire pregnancy if you're a normal weight person. If you're overweight, you get to gain 15. Now everybody talks about, oh, I gained 50 pounds when I was pregnant. That's because your doctor let you get out of control, because I'm the first person to tell you it's hard to get that weight off once you put it on. So we try and manage those things throughout your pregnancy so it's not a surprise at the end when you're the 75 extra pound lady with the little 6-pound baby. Right? We want you to make sure that you're not a gestational diabetic and grow a 10-pound baby and your vagina can only hold a 7-pound baby and I gotta fix that, right? So all of these things we mediate throughout your entire pregnancy. Biggest tip, see a doctor. Make sure that you get your prenatal care, come in so that we can take care of you throughout the entire process. The hardest part for me is when you show up at 40 weeks and you're delivering a baby and I know nothing about what's in your abdomen. What categorizes a patient as a high-risk patient is usually if they have if they're at advanced maternal age, which means over the age of 35. I know that doesn't sound advanced, but that's what the definition is based on your ovarian age. Or if they have had multiple fetal losses, or simply being an IVF patient may consider them a high-risk patient because these are such cherished pregnancies that we tend to watch them more frequently. Or if they have a chronic condition like diabetes, hypertension, hypothyroidism, or any other chronic medical condition. Pre-existing conditions affect the IVF patient similarly to how they affect any pregnant patient. Usually, as a generalist, I refer them to a maternal fetal medicine specialist so that they get the appropriate counseling and monitoring, and then I just do their regular OB visits. But at the same time, we monitor their blood pressures or whatever the chronic condition is to make sure that they're maintaining a healthy pregnancy. The hardest part with a IVF pregnancy is the actual conception, being able to maintain a pregnancy, or as they call it, keeping a pregnancy. So after they place the embryos in your uterus, it's a waiting game. We start the anxiety process with our patients of making sure that these pregnancies, as we call they take hold in your uterus, right? Because that's what we want them to do, take hold, build a home, and start their life process. And so that's the hardest part. Once they've been there 10 to 12 weeks, we think you're home free, and we try and get you there because most times when a woman miscarries, it's during the first 12 weeks of pregnancy. Some of the complications I see in particular with IVF patients is the anxiety that they feel. These are very cherished and wanted pregnancies, and when something goes wrong, it's devastating. Anytime there's a fetal loss, no matter whether it is a cherished pregnancy like an IVF pregnancy or any natural conception, it's a hard loss. It's not just a loss for the patient, it's a loss for us, right? Because your doctors and your nurses, my staff, we all feel your pain. But at the same time, my goal as your physician is to help you deal with this anxiety. I'm talking about, let's schedule you a massage. Let's schedule you a date night. Let's tell your husband, I'm gonna write you a prescription for sex on demand. I'm gonna write you a prescription for ice cream on demand. Whatever it's gonna take to get you through that 10 to 12 weeks, to get you to that common safe zone so that I can get you a healthy pregnancy. Now, most of my IVF patients are very high strung, because they're nervous about fetal losses. They go buy Dopplers online so they can listen to their babies at home. I don't typically recommend that because if you can't find a baby, you get nervous. I know how to find a baby. I know how to use a Doppler. If I can't find a baby, I do an ultrasound. You stress yourself out. I don't want you stressing throughout your pregnancy. My goal with IVF patients is to keep them calm and stress-free. It's almost an impossible goal, but we try. That's the best we can do. So IVF patients, the reproductive endocrinologist, it's like one of another colleague said they're doing a lot of BOGOs, which is buy one, get one. I have a colleague in town who does a program where he does a BOGO. So you usually pay about $10,000, and that includes, if you pay cash, for all the stimulating drugs, the ultrasounds, and they typically have ultrasounds once or twice a week when they're trying to implant embryos to stimulate ovulation and all of those things. So it's about a $10,000 to $15,000 process, a cycle. And a cycle is going from getting eggs to implanting them. And most of that is not covered by insurance, it's usually cash. So this is a medical legal issue. I'm not sure necessarily about the state of Florida and what they can do, but some people leave them frozen, and as long as they've paid their bill, they remain frozen. The implications of not paying your bill are already going unsaid. Or people leave them for other couples who want to adopt embryos, or they discard their embryos.